this whole space is, kind of a actively moving and a highly investigated target, both for its diagnostic abilities as well as its potential for theragnostics, meaning that you can tag radiohybrid labels to that have therapeutic potential. And so, I think to back up for a second here, and certainly it sounds like you have some familiarity with it, is that, the real problem is that, we've been historically asked to make a lot of decisions using tools that were really not that sensitive. And meaning that if we have a CAT scan or a bone scan or an MRI, they've all been limited in their sensitivity to some degree in detecting recurrent prostate cancer, or even, kind of metastasis at the time of diagnosis. And half of the problem is that, we know that if we can have an accurate understanding of where the location of that either recurrence or those metastases are, our treatments are potentially going to be better. And the other problem is that we know and have recognized for many years that if we treat you at earlier time points, if you're experiencing a recurrence, the outcomes will be better. And so if you historically had tools that weren't sensitive, and we're trying to make an accurate plan, we'd have to wait until, a time later on to really kind of accurately target those kind of recurrences. So instead of that, what we would do is we'd, kind of at early time points just say, well, let's guess based on probability that it's in certain locations, and let's, kind of either radiate or treat or perform systemic treatments to those areas, just because we didn't have any other ability to find those recurrences. So throughout time, just any kind of PET CT imaging really started to come into play. And again, there's been a whole history there. But more recently, in the past, probably now 5 years, PSMA has really started to dominate that scene, meaning a PSMA-targeted PET CT scan. And so a lot of the current PSMA radio agents have been shown and are even FDA approved to be used in the space of recurrence. But some of those agents, and actually almost all of them, have historically been plagued by the fact that they have a lot of excretion within the urinary system. And so this radiohybrid PSMA flucyclovine molecule is actually modified in such a way that it's really not highly excreted within the urine. And that potentially allows for increased detection within or around that urinary symptom and or bladder, which could otherwise be masked by its normal metabolic processing. So that was really kind of the basis of this study, is to say, does this hybrid PSMA molecule have utility in detecting recurrence? And specifically, the current study was really a subset of what was called the Spotlight study. And the Spotlight study was a prospective trial that evaluated the utility of the radiohybrid PSMA agent among men undergoing a recurrence. And that recurrence could have happened after either surgery or radiation. And so this specific subset study looks particularly at the ability of the agent to detect recurrence among men who initially had radiation as their primary therapy. Well, I think it's all quite impressive, is to say that, especially after radiation, and these tend to be, kind of higher PSA levels. So again, when you radiate a prostate, your PSA never goes to 0 for most men. And that's because your normal prostate is still within the body. So there's always some kind of baseline PSA expression that's going on. So by the time you actually determine that a patient is recurrent, the PSA levels, can be, kind of a value of 2, 4, 6, et cetera. And so at those levels, which is, kind of the normal and expected levels after radiation, 99% of patients, we were able to use a scan and detect a recurrence. Now, 42% of those who had a positive scan was confined or had recurrence within the prostate. So that's interesting to know that it was kind of a local recurrence or insufficient, if you will, targeting of the radiation or to that prostate cancer within the prostate. 25% of those that had a positive scan had pelvic lymph node recurrence. But I kind of find that the most interesting thing is that 43% of those with a positive scan had distant metastasis that was outside of the pelvis. And so that really is a big factor because that is really going to change the treatment plan. We have really kind of gone from kind of a local, kind of focused, targeted treatment to something that usually becomes a little bit more systemic. And a lot of times when we're expecting recurrence, we usually kind of expect it really locally. And so this, I think, to me, was the biggest surprise, was that 43% of them were really kind of outside that pelvis. I mean, the other part of the study, which is somewhat, kind of more expected, is that, men who initially had, higher Gleason scores at the time of diagnosis, higher baseline PSA or kind of lower PSA doubling times, were more likely to have extra pelvic lymph node metastases. That's, kind of expected what we know in the literature. So it kind of it is at least following what we would expect to say, hey, based on these characteristics, these are the guys who are more likely to have these, kind of extra pelvic lymph node metastases. On the other hand is, again, historically, these weren't really seen with many of the other kind of technologies. I think there's a lot of still unanswered questions. I think currently, if this is what we had, it's pretty good. But I do think, with the current abilities of this PSMA agent, that certainly it's going to help change our management from potentially, kind of focused treatment, saying, hey, we can use or spot, if you will, radiate certain areas, with SBRT in the pelvis. But certainly once it gets to distant metastasis, we really got to be using, kind of systemic therapies, often, kind of dual agent hormone therapies to really kind of get that. So it really kind of helps focus those treatments appropriately, avoid unnecessary treatment to potentially areas that wouldn't be involved. But certainly apply more systemic therapies at earlier time points to men who really already have advanced cancer. I think the unanswered questions is that, how does, kind of the PSMA PET CT agents, compare to more historic, even now PET CT agents? Meaning that there was other, even flucyclovine labeled, kind of agents that Axumin that took advantage of an amino acid transporter versus PSMA. How do those agents compare? Are they going to detect similar patterns or different patterns? How do these perform in the, kind of hormone sensitive or castrate, kind of resistant cancers? And so I think that, a lot of that will hopefully be answered with time. And then ultimately, where do we apply this? Is that, do we use these on every patient with a recurrence? If you have a negative PSMA scan, do we consider, other agents, Axumin scans, How do these correlate? What happens if we combine these with MRI imaging? So I think, again, there's a lot of really kind of exciting questions still yet to be answered. And so, I'm really kind of energized by this field because of that.